Now it gives me great pleasure to introduce the president of Friendship Heights Neighbors Network, Evan Smith.
Thank you, Louise. I'd like to welcome everyone and thank you all for joining us. Our program today has been organized by Friendship Heights Neighbors Network and Dr. David Rabin, a member of our board, with the help of Little Falls Village. For those of you unfamiliar with the Village movement, we're neighbors helping neighbors to age at home and lead fulfilling lives. Dr. Rabin formerly led the Health Services Research Department of the Georgetown School of Medicine and the American Public Health Association section on gerontology. He will now introduce our speaker, Dr. Carrie Graham. Dr. Rabin.
Thank you, Evan. Our speaker today shares some of our personal interests. Earlier in her career, she was involved with a national study of senior villages, so that she shares our interests and our concerns and respects what it is that we represent. Dr. Graham has been a researcher for some 25 years with a focus on health policy and aging research. She has a gerontology master's degree from Miami University and a doctorate in sociology from UCSF. She's been a House Ways and Means Committee fellow working on Medicare oversight, and in her work consults extensively with states on planning for their aging programs. She holds the distinction of having academic appointments on both coasts, serving as research professor and director of the Medicare Policy Initiative at Georgetown University Health Insurance Center on Health Insurance Reform, and as adjunct professor at the UCSF Institute of Health and Aging. Dr. Graham, I look forward very much to hearing your talk.
Thank you so much, David. And before I share my slides and start my talk on healthcare changes, I just want to say thank you for being here, and I am thrilled to be here. Early on in my career, I remember back in, I think it was 2006, there was a New York Times article that talked about this new thing called a village that was created in Boston. And I had been a gerontologist. I have studied aging. I worked my way through college as an activity director in a nursing home, and from there have always worked in aging services and research and aging and disability policy. And so when I read about this, I was like, this is really interesting. And I ended up working with a bunch of friends who created a village called Ashby Village in Berkeley. And I was originally on the board of that village. And then I ended up at the time I was working at UC Berkeley, ended up getting a bunch of research grants to actually study villages. And for about 10 years, doing studies of some villages in California and a national survey of villages was kind of one of my main research areas. So I, gave talks at the Village to Village Network national gatherings. And so villages are certainly close to my heart. And I'm just so happy to be able to be here with you all today to talk about some of the changes in Medicare and Medicaid. And now, I think as mentioned, we're going to hold off on questions till the end, but feel free to put questions in the chat at any time. As David mentioned, I am an expert in aging policy, federal policy, and state policy. But what I'm not a doctor. I'm also probably would not be the best person to talk about your particular situation in terms of choices for enrollment and things like that. So, but I can refer you to folks who are really good at doing that kind of benefits counseling. So I might not be able to answer kind of more particular questions about things like eligibility or coverage, but just want to go over some of the basics today through my work at Georgetown and federal policy. So what we do right now at Medicare Policy Initiative is that one of the biggest things we do is technical assistance to Congress and the administration. So we are nonpartisan. We are not associated with any party. And we also don't take money from the healthcare industry. We don't take money from MA plans or provider groups. So we try to be very independent. And what we'll do is if a new policy comes out or a change comes out, we will write something or work kind of confidentially with a Congress member's office to talk about, okay, if you're trying to do this, this bill is or isn't going to accomplish it, or what are some of the challenges with this policy? So we do a lot of technical assistance and kind of rapid turnaround policy analysis. Right now, I'm really focused on Medicare and Medicare Advantage. In different times in my life, I've been very focused on Medicaid. I am not an expert on the Affordable Care Act. I'm going to try to cover some of that today, but some of the changes, because those are some of the major pressing changes that we're seeing in a lot of the discourse. But if I can't answer your questions on Affordable Care Act changes, I can refer you to folks. So,
I'm probably not available, but call me tomorrow.
I think somebody needs to go on mute.
Yes, please mute.
Okay, so the talk today is really just sort of, I was thinking, what do older adults need to know about the impending changes to healthcare coverage? And I'm just going to be talking about a few different things. Obviously, we'll talk about the One Big Beautiful Bill Act. It often has different acronyms. We can also there's also been a lot of just regulatory actions and changes, DOGE, changing the structure of agencies and different executive orders and regulations being put out. But overall, we're gonna touch on some of the changes that we're seeing to the Affordable Care Act, which directly impacts the state health insurance exchanges when people need to buy their own coverage. We're going to talk about some big changes to Medicaid coverage. We'll talk about some of the changes to Medicare that we're seeing. I definitely want to talk about some of the changes to long-term care, like in facilities and nursing homes and home and community-based services that we're a little worried about, and telehealth. And then because I'm working really closely on Medicare Advantage issues right now, I'm going to end with just some discussion around Medicare Advantage and the open enrollment and some of the changes you might see there. So HR Run, the Big Beautiful Bill Act, it was enacted on 4th of July. Because it was a budget reconciliation, it wasn't subject to filibuster. So they kind of tried to cram everything in there because it only needed a majority to pass. It didn't need 60 votes. It really restructures Medicaid and makes some major changes to the Affordable Care Act. Less impact on Medicare provisions, but we'll talk about those. Overall, I would just say it generally lowers federal spending on Medicaid, but it increases federal spending overall. And with a lot of these changes, we're seeing estimates of 10 to 17 million more people uninsured. And this is after, in the US, we made a lot of progress with really, really reducing the number of people who are uninsured. And this will increase that amount. And because of that, it will have some major impacts on hospitals, nursing facilities, doctors' practices, especially those who rely on getting reimbursed by Medicaid, and especially in rural areas. All right, so the Affordable Care Act, one of the major things it did was it created state health insurance exchanges. And it made it so that individuals who don't have coverage, if you're don't qualify for Medicare or Medicaid, and you don't get insurance through your employer, or you have an employer who doesn't offer insurance or something like that. Every state has a exchange where you can buy different plans. And these plans, due to the Affordable Care Act, it did things like saying insurance companies, you probably remember when insurance companies could deny you care for a pre-existing condition or raise your rates for a pre-existing condition. Can't do that anymore, thank goodness. But it also did some things to make these plans affordable. And so one of those was to provide premium tax credits to people of all different incomes within 400% of the poverty line. It also ensured that what you're paying for these plans don't exceed a certain percent of your income, and that made it more likely that people would buy plans. If you want everybody to be buying plans and covered, you don't want healthy people not to be buying, to go uninsured and not buy plans, because then you have this issue with if you don't have healthy people buying the plans, you have an issue with the risk pool being sicker and then being more expensive for everybody. So really made a lot of effort to make these plans affordable. And so one of the biggest things that people are really worried about is the elimination of the premium tax credits. So it would take away these tax credits for people below 400% of poverty, and the guarantee that it would only it wouldn't exceed a certain percent of your income. So this is very, very worrisome for folks, because we are seeing this that in a lot of areas there is going to be double and even triple the cost of the premiums. And I'll give you an example of that in a second. Another thing it does is has stricter income verification rules and more burdensome and frequent verification rules. This depends on the states. They can modify that a bit, but it just makes it more likely that people cannot, because of paperwork errors or things like that, they will be punted off of coverage. It also restricts coverage for lawfully present immigrants. And so I'll cover this in a little bit, but it's really, people who are lawfully present, but they have like refugee status, are no longer eligible to buy insurance off these exchanges. There are some exceptions to that, like people from Cuba and other exceptions. And there's narrower, the ACA said plans have to cover these certain health benefits, and there's narrower definitions of the different essential health benefits. And so, as I said, this is going to really increase people's premiums and what they're going to spend on health insurance. It could really reduce marketplace participation among younger, healthier people who just would not be able to afford a plan. And it compromises the risk pool, and that also increases premiums for everybody if the healthier people don't join. So just, I think it's not talked about enough about, sort of the kind of ages pre-Medicare, people who are like 50 to 65, 55 to 65, who need health insurance and before you're qualified for Medicare. And I'm 55. It's becoming really my cohort now. I'm getting a lot of questions from friends of, maybe they've been laid off due to ageism. They say it's harder for a 50-year-old, older than 50-year-old woman to get a job than it is for, I don't know, a camel to go through the eye of a needle. Getting laid off, don't have work, or they had to cut back on work due to caregiving responsibilities, which is a very common reason to stop working later in life. Or maybe they just simply want to retire early. Personally, I've had a job since I was 13. I'm 55 years old, and I wouldn't mind retiring before the age of 65. But that would mean that I would need to buy an exchange plan to cover me until I get my Medicare. It could also be self-employed people who would need to buy insurance through the exchange. So as an example, if a couple makes $85,000 a year, they would have previously qualified for a premium tax credit. Now, according to this online calculator, I put that you can look up your region and see how much that would increase. But estimates are that premiums would jump from about $7,000 a year to $25,000 a year for this couple. They're just in the they're just within the 400% of poverty range, so they're no longer going to get a premium tax credit. So if you think about 5 years, someone would have to have $125,000 saved if they want to retire at 60 to cover their health insurance until they get Medicare. So this is a big, big deal. So changes to Medicaid. So switching over from Affordable Care Act to Medicaid. There's a really important reason to care about Medicaid. You know, I do feel like messaging is often out in the world like Medicaid, that's not me, that's somebody else, that's poor people. Those are people who haven't worked, or those are people who just aren't me. And a lot of times people don't really care so much, or they just don't feel like it's personal when Medicaid gets cut. But there are reasons why, even if I'm not on Medicaid, I should care about that. And one statistic that I think is important, it's a little depressing, but people, if you reach age 65, 70% of people are going to need long-term care at some point in your lives. Between 65 and for the rest of their life, there's a 70% chance. And Medicaid is often the primary payer, even if people aren't low income. You know, if you end up in, let's say you get in an accident, you break a leg, Medicare does cover post-acute care for a certain amount of time, up to 100 days if you're getting rehab after that hospitalization. You have to be like actually improving and all of that to actually get it covered. But once that's not covered anymore, if you still need long-term care and long-term services and support, especially if you need care that's not skilled, meaning you need help with dressing and bathing and things like that, not like nursing care, Medicaid, lots of people end up spending all of their savings or spending down to be eligible for Medicaid. And this can be people who've worked their whole lives, who have substantial savings that can go away real quick if you need long-term care. So some of the changes to Medicaid are it's increasing work requirements. Some states already have these, and it's requiring people below the age of 65 to work 80 hours a month and document that. And there's going to be pretty frequent eligibility redeterminations. Like you have to submit this paperwork over and over and over again. This can be different in different states, but that will just make it harder for people to stay on and end up just getting punted from coverage because they mess up on the paperwork. So that's an element of savings. The other thing that's happening is that there's something called provider taxes. So all 49 states, except for Alaska, have these provider taxes. And it's been framed as sort of like a scheme in states, but it really is like they tax providers or Medicaid managed care plans, and then they sort of pay them back in a certain way, and that increases the federal match. And so that is just something that is going to reduce states' Medicaid budgets. There are stricter immigration and citizenship rules. As I mentioned before, there's always been restrictions on, illegal immigrants, people who are totally undocumented, have never been able to get Medicaid, but this is limitations on some people who are lawfully present. And it also limits these state-directed payments, which is sort of these payments to providers of Medicaid. And the interesting thing about these payments is that it's going to restrict, and you'll see this kind of all the way through, it's more penalties for states that expanded Medicaid. So another thing the Affordable Care Act said is, instead of having to be under 100% of poverty to qualify for Medicaid, that is so poor, that if your state wants to, they can expand Medicaid to people within 138% of poverty. And some states did it. The states who didn't tend to be more like red states and states that were sort of ideologically opposed to expanding Medicaid. So this provider payment restriction, it restricts provider payments to 100% of Medicare in states that expanded Medicaid. But states that didn't can pay 110% of the Medicare rate. And it just makes it so there's more, you can increase rates and get more doctors and providers to take Medicaid by paying them a little bit more. Because it's always hard to find doctors who take Medicaid. But this is an example of like the states that expanded Medicaid getting kind of punished in a way. So, what everyone's talking about in these Medicaid cuts, it's supposed to, save $911 billion in federal Medicaid spending. But this is at the cost of significant coverage losses, not just for people on Medicaid who lose coverage, but also for people on Medicaid who, states have some flexibility of what they cover. They can cover, there's certain benefits that have to be covered, but there are also benefits that the state can say, you know what, we're going to cover that. One of those is home and community-based services. So what states, when they see their budgets contracting, people who are on Medicaid might see in those states the services they're getting and their benefits going away. So they can cut optional services. That's what we're talking about. So for example, in federal law, the only long-term care that's required to be covered by Medicaid is care that's provided in a nursing facility. And I think you all, as part of Villages, probably are in agreement with most people in the US who say, I don't want to if I need that kind of care, I don't want to get care in a nursing home, I want to get care at home. But that's not covered by Medicaid. That's not required to be covered by Medicaid. It's an optional service that states can decide to cover. And so states can apply for home and community-based service waivers saying, we want to take some of our Medicaid money that would have gone to long-term care in a facility and provide home care for some people. These waivers aren't great. It's not universally provided. It's usually limited by a wait list. And, it'd be better if federal law said you had to cover home and community-based long-term care, but it doesn't. But at least most states have one of these waivers. So they cover certain geographic areas with home care, or they have like slots, so there's a waiting list. But anyway, this is a kind of optional service we're worried about getting cut. There's going to be a lot of variation across states. They can, different states can kind of decide the degree of strictness in terms of how often they're going to make people do income verification. And we are really worried about rural areas. And so, hospitals, clinics, nursing homes in rural areas really rely on Medicaid payments. And so this is something that, most people in Congress really care about rural areas, and they've created this rural transformation, new funding stream. It's $50 billion. It's only for a couple years. It certainly adds complexity. It's kind of like create a problem and then try to fix it. But health facilities, hospitals, nursing homes, health systems can apply for this if they are in a rural area and get some funding to mitigate, so to make sure they don't close basically and leave rural areas with no healthcare providers. It's temporary. And it really just, one thing that really bugs me about the US healthcare system is like when we find a problem, we sort of layer more complexity to fix that problem. So instead of fixing the Medicaid cuts, there's just another funding stream they have to apply for. They have to hit benchmarks. They have to it's just a lot more administrative issues. Okay. Medicare didn't get changed as much in the Big Beautiful Bill Act, but it did have some changes, and there's some other changes to Medicare. So it just like ACA and Medicaid, stricter eligibility policies. So the people who can still get Medicaid. So just to say that when people come to this country, if they're working, even if they're undocumented, they're paying taxes. Um, if they're getting a paycheck, they're usually paying taxes. After this bill passes, so being eligible for Medicare, you have to be either a U.S. citizen or hold a green card, or there's a special thing for Cuban Haitian entrants, and those residing on compacts for a free association. I don't know what that is, but there's certain groups of lawful immigrants who can still get Medicare. But there's others who are here legally, such as those with temporary protected status, refugees, and asylees, who, even if they're here legally and have been paying into Medicare, they can no longer get it, which so, and it's these same kind of rules for Medicaid and ACA. And this will terminate Medicare coverage in about 18 months for anyone who is not covered under the green card or Cuban Haitian immigrant rules. It's going to reduce Medicare spending, they estimate, by about $5 billion over 10 years, but it increases the number of uninsured by 100,000. The other big change to Medicare is this thing called the Medicare Savings Program. And you'll see, kind of a theme here in coverage for people who are low income. And so Medicare Savings Program is a program that if you're a Medicare beneficiary and you're low income, you can get help with things like the co-payments and that you might otherwise have to pay. And it's a program there were a lot of barriers to enrolling in this, and a lot of people who qualified weren't enrolled. So the Biden administration tried to make it easier and get rid of some of the barriers to enroll, and that got rolled back by the Big Beautiful Bill. So it basically, takes away and re-implements some of the barriers to enrolling in Medicare Savings Program for low-income people. 1.3 million low-income Medicare beneficiaries are projected to not have it anymore and have the increased costs in terms of like their copays and all that, reducing federal spending by $66 billion over 10 years. It was kind of interesting because some other changes were to sort of put more money into investigation of fraud in traditional Medicare, that's fee-for-service Medicare, not Medicare Advantage. Something that was not in the bill that they've just announced, but it hasn't like regulation or anything, is that they do want to use AI to do more expanded audits of Medicare, the payment to Medicare Advantage plans. It's not well fleshed out. It's not part of the bill, but the only thing that was in the bill was looking at fraud in traditional Medicare, which is kind of interesting because fraud and overpayment in Medicare Advantage is a lot more money than fraud in traditional Medicare. Fraud in traditional Medicare certainly exists. There's terrible stories of, providers going to assisted living and ordering crazy tests for everybody there just to make money. I mean, there's definitely fraud in regular fee-for-service Medicare. But there's also issues with overpayments in Medicare Advantage and kind of gaming the system that was not in that bill. The other thing that kind of bothered me, because I was in this world for a long time, is there's never been federally recognized staffing minimums for nursing homes. I don't know if you've ever, visited someone in a nursing home, But one of the big problems in nursing homes, skilled nursing facilities, or rehabilitation facilities is that there's often not a lot of staff, and that's because they pay them very little, and there's few people who want to work in these settings, often relying on immigrants to work in these settings. And another thing that contributes to people not working there is understaffing, because you do work there, you just don't feel like you can do a good job. So some states have requirements for minimum staffing, saying you have to have a certain number of nurses and certified nursing assistants if you have a certain number of people with a certain acuity of care. You're all probably familiar with, there's quite a bit of abuse that happens and neglect that happens in nursing facilities, which was exacerbated when COVID hit. So the Biden administration, for the first time, had federal requirements. And these were, this is really based in evidence and research, and they were really basic requirements that you have to have an RN on site 24/7 in a nursing home, and you have to have a minimum of 3.48 total nurse staffing hours per resident per day. And this is like not very high. And this got rolled back by the big beautiful bill. Basically, it was a finalized rule that you're able to serve rollback if it's within a certain number of years, and that happened. The nursing home industry was really against this rule and did a lot of lobbying against it. But if you think about, like, nursing facilities rely a lot on Medicaid payments, so they're going to have fewer Medicaid reimbursement because of the cuts to Medicaid. And then they're not going to have requirements for staffing. So what we're worried about is that, to make up for the lower Medicaid payments, they will reduce staffing. And we all know what that means for people in nursing homes, who are probably the most vulnerable people to abuse. Some other things it did, providers were very upset about, reducing Medicaid payments. And so they got a temporary bump of 2.5% in payment to physicians taking Medicare. The other thing to note is that in the Biden administration, there was the Inflation Reduction Act. And for the first time, Medicare, one of the biggest purchasers in the world of medication, was able to negotiate prices, to reduce prices. This was strangely very contentious. It was hard to do because the drug industry kind of said, you can't have government, setting prices. But anyway, it passed. But there were these certain drugs that they called orphan drugs that aren't eligible for negotiation. And this is drugs that really are usually super expensive, but they're like special drugs that are the only drug that treats a certain serious condition. And so the big beautiful bill kind of addressed concern from the big pharma, and they kind of loosened the definition of orphan drugs. So more drugs can claim that they are orphan drugs. And this actually increases Medicare spending by about $5 billion over 10 years. Another thing to pay attention to, this isn't really the big beautiful bill, but it's the telehealth flexibilities. I don't know, I'd be interested to hear if any of you have had any sort of virtual visits canceled. But during COVID and subsequently, they made it a lot easier for doctors to get reimbursed if they meet people in telehealth visits online. And everyone has really liked this, and it's really expanded access to care for people in rural areas, people who can't travel, people with disabilities who may not drive. And so they keep expanding it, like 3 more months, 6 more months, a year. Well, the flexibilities ran out October 1, and then the government shut down. So what we're seeing are health systems and provider systems who are saying, like, should we cancel all of our telehealth visits? You can imagine what this would do, especially in safety net hospitals, that so many people, in the next few months have telehealth visits. If those get canceled, these are people who may not be able to come in. The system might not be able to fit people in person. Right now, we're seeing most health systems are continuing with that. But what needs to happen is first, the government needs to, a continuing resolution needs to be passed. They would also need to pass a extend the flexibilities, and they need to make it retroactive so you could pay for any telehealth visits that are happening during this time of the government shutdown. On the plus side, the big beautiful bill made it so that health savings accounts, which are accounts for people who have high deductible plans, were able to permanently pay for telehealth. So there is some understanding that telehealth has really turned out to be a really valuable service. Overall, I would say there are some major, populations to just want to emphasize the impact on immigrants. So, obviously, we've talked about already that ACA marketplace coverage for some lawfully present immigrants is going to expire January 1. That's coming up very soon. And some of the eligibility restrictions for Medicaid and CHIP go into effect October 1, 2026. So those are coming up fairly soon. The other thing you're seeing happen is like California, that budgets are getting squeezed, especially with all the cuts to Medicaid and things like that. So there have been some states, 3 of them are California, Illinois, Minnesota, and DC, had created these like state-funded programs to fund immigrants who don't have coverage. And it's really for the hospitals and for the providers who want to, if they have someone who comes in who's an immigrant who doesn't qualify for any health insurance, it basically is a way to pay that health system so they can continue seeing them. And 3 states in DC have now, made moves to get rid of those optional spending because they're just so worried about overall budget deficits due to all of this. And so just an example of, squeezing overall. And then the other thing, this wasn't part of the big beautiful bill, but back in August on 2025, people who are DACA, the Deferred Action for Childhood Arrival, these are the people who maybe they got brought undocumented to the US when they were a child. Many didn't even know they were undocumented till they, tried to go to college or something. And Obama made it so they had certain paths to citizenship, and those were rescinded, and they become, undocumented and not eligible for ACA marketplace. So just in terms of a case study, and some of this comes from my husband is a provider at a safety net hospital in California. And so, if a immigrant, maybe they have legal refugee status, but now they're no longer covered by Medicaid or Medicare or ACA, I should have put in there. They can't make appointments with a primary care doctor. They can't get medication covered. If they're having an acute illness, they can still go to the emergency department for care. Providers take the Hippocratic Oath. They're not going to turn people away from the emergency department, although we have seen J.D. Vance talk about that a little bit. But if they go to the emergency department, there they might get some care. They could be handed medications, but they can't make any follow-up appointments. They can't get any medications after that. And the hospital is not going to receive any reimbursement for that. So you can see that it puts hospitals in a strained situation. Louise, how am I doing on time? I do want to talk about Medicare Advantage. This is my specialty area. This is what I've been working on a lot. This is what the Medicare Policy Initiative focuses on. And I'm assuming many of you or most of you are on Medicare or close to a situation where you are getting your health care through Medicare. Other ways to get Medicare health insurance would be retiree health insurance benefits. Sometimes they offer MA plans. But originally, Social Security Act in 1965 created the Medicare program, and also created Medicaid. In 1997, they made this choice to say, you know what, we're going to allow, instead of just having the Medicare program be fee for service, meaning you have a card, you go to a doctor who takes Medicare, they're certified with the federal government, then they basically send a bill to the federal government for each service, fee for service. In 1997, they created the Medicare Plus Choice program, and it's for the first time allowed private health insurance, Humana, United, Cigna, all of these, to offer Medicare beneficiaries to get their Medicare through the plan. But it also gave flexibilities to why would someone want that? It gave them flexibilities to offer services that were not covered in Medicare, and we'll get to that. In 2003, they basically changed the name to Medicare Advantage and changed the payment, the way they're paid, and they created the prescription drug benefit. And a lot of MA plans include the prescription drug benefit. And by 2024, there was really this increase in people enrolling in MA plans, and it basically tipped over half of people enrolled in MA. So it became a big deal. Any changes to the MA plan have a really big impact then on the budget because so many people have it. There's some basic differences between traditional Medicare and a Medicare Advantage plan. As I said, traditional Medicare is fee for service. You're supposed to have a choice. It's actually supposed to be illegal to be forced into a Medicare Advantage plan. But the problem with fee for service is there's no incentive for providers to choose lower cost care. We saw a lot of problems with, providers, doing a lot of procedures and things that were reimbursed at higher rates. So there's, fee for service is not a perfect system. And so the nice thing for beneficiaries is they can go to any Medicare provider anywhere in the country. If you spend the summer in Maryland and the winter in Florida, you can see a provider anywhere. If you're visiting someone in Arizona, you could see a provider anywhere. If you want a second opinion at the Mayo Clinic, you could go see a provider there. And very few services have any kind of prior authorization like you see in Medicare Advantage. Medicare Advantage plans is a managed care delivery system. You may have heard the term HMO or PPO. You can get different ones that have different levels of managing your care. Plans are paid because they get a capitated payment. One payment, they look at your diagnoses, they submit those to the federal government, and based on your diagnoses, they get a per member per month rate. They have an incentive to submit more diagnoses to get a higher rate. They're not paid by the care. So the way they're trying to work it is, we're going to get this monthly rate for you, and we're going to try to make sure that we spend less on your care than the monthly rate, and that's how we make profits. MA plans, last I saw, made about $2,000 per member per year in profit margins. They have obviously financial incentive to reduce utilization and reduce low value care. That means really expensive stuff that doesn't help you very much. And they're very good at doing that. They really do reduce low value care. The trade-offs are limits to provider networks and obviously utilization management and prior authorization, which you're hearing a lot about probably right now. I'm hearing a lot about it. Why do they choose it? It's because you have lower out-of-pocket costs. MA plans can cap your out-of-pocket spending, and they can lower premiums and cost sharing. In traditional Medicare, the cost sharing is it's not like for a hospitalization, it's not always a copay. It's a percent of your hospitalization. So you can really get hit with co-payments in traditional Medicare unless you have a Medigap plan that covers those. The other thing that's really attractive to a lot of people in the marketing is that they offer these supplemental benefits not covered in traditional Medicare. So they'll offer dental, vision, and hearing. Most plans do that. And then some non-medical benefits like gym memberships or cards for over-the-counter payments. It's not always clear what they provide, but they certainly market that they do. Some of the problems with MA. One thing a lot of people don't know is that once you're in MA, you can be kind of locked in. Now, legally, you can always go back to traditional Medicare, and you can always change a plan during the open enrollment period, which is coming up. But you can't always get a Medigap plan. So as I said, if you're in traditional Medicare, it's really important, unless you have an unlimited budget, to get some sort of supplemental Medigap plan that covers your co-payments, or you can be kind of in trouble in terms of if you have a big hospitalization, you can be charged a lot of money. Medigap plans, when you first become eligible for Medicare, they are what's called guaranteed issue, meaning there's a certain rate in each state. They're kind of expensive, but they can't take into account your health conditions or anything like that. And it's called guaranteed issue, and you get that when you first enroll in Medicare. But after, depending, 6 to 12 months in MA, if you want to go back to traditional Medicare, you will not have guaranteed issue for a Medigap plan, and they can be really unaffordable. So you can be kind of locked in. Agents and brokers are supposed to tell people that, but it's not always clear. The other thing I mentioned before, there's a lot of reports right now. I think we've kind of reached the tipping point in prior authorization and the denials in care that people are managing. You see a lot of providers exiting MA plans and saying, I'm not going to participate anymore. I'm spending 20 hours a week dealing with these denials and appeals. And it seems like we've kind of hit a tipping point. People are getting, providers and people are getting sick of it. The other thing that is happening is that the current administration has created these models that get tested, but most of them are to do more prior authorization on certain services for beneficiaries in traditional Medicare. So that's sort of something that people are kind of a little riled up about. It's small testing demonstrations in certain states on just a certain set of services that are known to be pretty low value. But people are concerned about a slippery slope with more prior authorization traditional Medicare. Another major problem with MA plans is this issue of upcoding. I think I mentioned before, plans are paid in a different way. They're paid amount every month for you. The way they determine that is they submit diagnoses to CMS. And one of the things they do is they kind of, they're mostly for profit, some are not for profit, but they sort of dig for diagnoses to make sure that they are getting the maximum payment. And so I don't know if any of you who are on an MA plan, the plan might call you up and say, hey, we want to do a home visit to make sure you're getting the care you need. So the plan, it's not your doctor's office, could send someone to your home or do a virtual visit where they do what's called a health risk assessment, and they kind of talk to you about any issues you have. And part of that is to make sure you're not missing care, and part of it is to find diagnoses that they could add to get a higher payment for you. The other thing that they do that comes under criticism is using AI to review electronic health records and chart reviews to sort of dig for additional diagnoses. They do get audited for this. A small sample of plans gets audited for this every year. But if you think about it, one of the rationales for allowing private health insurance plans to offer Medicare benefits was like, the free market, and it will sort of, competition will reduce costs and increase quality for plans. But what we're seeing is that actually analyses all over the place say that the federal government is actually paying 20% more for beneficiaries in Medicare Advantage than they are for those in traditional Medicare, which is, opposite of what it was supposed to do. So that's coming under some scrutiny. The other thing with open enrollment coming up is transparency and choice. Now, when MA was first established, it was called Medicare plus choice. And there's this big emphasis placed on, people want choice, want to provide choices. In my opinion, that's gone a little bit overboard with a lot of Medicare beneficiaries having over 40 plans to choose from. There used to be more restrictions on the number of plans, but there's usually a lot of plans to choose from. But MA plans are not so good at transparency, especially when it comes to beneficiaries kind of trying to find information about the plan. First of all, it's often really hard to find out if your provider's in the plan. There's some changes to the provider, the Medicare Plan Finder, where they're trying to put the provider directories online this year. But providers can drop out at any time and say, I don't want to be part of this MA plan anymore, whereas beneficiaries can only change once a year. So it's kind of hard to know sometimes if your provider's in the plan, and I mention that because it's often the most important thing to people is making sure their provider's in the plan. So that can be hard to tell. Also, if you're shopping for a plan, you'll see quality scores. There's 5-star ratings. Most plans figure out how to be 4 stars or more. They get paid a lot more if they have higher quality scores. But when you're looking at those quality star ratings of a plan, you're not looking at a quality rating for your plan, the one you're joining in your region with a provider network in your region. What you're looking at is a quality score for every MA plan that company has in a contract. That can be 300 plans across 11 states. So it's not really a score for your plan. So that's kind of not great for beneficiaries trying to look at the quality scores because, they can add and subtract plans from a contract and increase the quality scores. So it's not all that meaningful. Sometimes with those supplemental benefits, there's a lot of advertisement. You've probably all seen, late night on CNN, there's do you want dental, vision, and hearing with your Medicare? And so most plans offer dental, vision, and hearing, but they're not always super transparent about the scope and eligibility for those supplemental benefits, especially the non-medical ones like transportation or over-the-counter cards, because to be eligible for those, a lot of times you need to have a chronic condition, which isn't really in the marketing. Oftentimes it's hard to tell, oh, they're going to offer dental. Well, are there dentists in my region who take it? Are they 100 miles away? How much will they actually cover? So oftentimes when you're shopping, it's not really clear what those supplemental benefits actually are. Another thing that I would like to look at when shopping for an MA plan would be like, how often do they deny care? Especially if I know I have certain kind of services I need. And right now, these changes are probably coming, but they don't really have to report. They kind of report at the contract level how often they deny care, but it's not really at the plan or service level or easy for beneficiaries to find that out. Another thing that you should be aware of is there's been a lot of, you may have read newspaper articles about questionable marketing practices. Certain plans, there's a lot of brokers and agents out there. They make money when they enroll you in an MA plan. And the federal government says you can't pay them more than this amount if they enroll people in an MA plan. Notably, they get a lot less if someone stays in traditional Medicare and they sell them a Medigap plan. So brokers and agents have an incentive to get people in an MA plan. There's ways around how much MA plans can pay brokers, and we're seeing that the federal government sued them because they were like using other money to do like kickbacks, like golf trips, and just trying to get these brokers and agents who are supposed to help people find the plan that's right for them, refer people to that plan. One of the things they're a little worried about is this thing called state health insurance programs. These are volunteer counselors in every state who are unbiased. They don't get any money for referring you to a plan, and they're one of the few unbiased sources. There may be less. Right now, they're funded at the same level, but there may be issues coming in terms of that funding. One of the things that we see in trends is that when people are younger, maybe you're 65, you're getting on Medicare, you're used to an HMO, and you don't really have a lot of conditions. You don't really see yourself needing to go to Mayo Clinic for anything or needing second opinions. And so an MA plan seems fine. What we do see is that when people begin to have health conditions and need more care, they're more likely to switch back to traditional Medicare. And we do see people in traditional Medicare tend to have more health conditions than those in MA. So anyway, open enrollment for MA begins October 15th. I was just asked by Newsweek, did an article that government shutdown should not be affected by the shutdown, except that, I mentioned the Medicare Plan Finder. You should definitely look at it online if you're choosing a plan. This year, they're trying to include provider directories. Mostly they're just provider directories that you click on a plan and it takes you to the plan's website. But every year, they load the information for all the different plans that are available into the Plan Finder. And usually there's some fixes that have to happen before open enrollment starts. Now that the government shut down, those fixes won't happen. So there could be some glitches there. For unbiased advice, just to reiterate, go to your Maryland State health insurance program counselors. Actually, somebody on our team is a volunteership counselor. So that's a really good place to find information. There's also, if your MA plan is discontinued, and you are seeing probably that a lot of MA plans with some restrictions have discontinued offering plans in certain regions that are less profitable. Vermont, I think, is actually really affected. The United Healthcare stopped offering MA plans in Vermont, so a lot of people, the majority of people in Vermont who are on MA were on that plan. If a plan goes away, you can get this thing called a special enrollment period. And what that does is it allows you to, switch to a different MA plan, but it also allows you to go back to traditional Medicare if you want, and it gives you that guaranteed issue for the Medigap plan. So if your plan was discontinued, just know that if you were thinking about going back to traditional Medicare and wanted to buy a more affordable Medigap plan, that would be the time to do it. They are also saying that if you get some sort of false, if you go in the Medicare Plan Finder and it says it has your doctor in a plan and that's not true, you can call 1-800-Medicare and get a special enrollment period. I don't know how that happens. I don't know what they check, but it is another way. So between January and March, if you find out that your provider is not really in your plan, you can call up and get a special enrollment period for the first 3 months of the year. So anyway, not to end on a negative note, but there are things I'm worried about for older adults. I'm worried about access to home and community-based services, home and community long-term care in people's homes. As I mentioned, this is often an optional service, and with cuts in Medicaid, it could be the first thing that states cut, which would mean if you're on Medicaid and you need long-term care, you'd be forced into a facility. I'm worried about reductions to Older Americans Act services, which are, I haven't talked about those a lot, but there's this agency called the Administration for Community Living that's actually being dissolved. And it was sort of responsible for services that are funded under the Older Americans Act, like SNAP benefits and SHIP programs. There is, in the Big Beautiful Bill, new income eligibility requirements for nutrition programs. It used to be that over age 55, you didn't have to show what your income was, and now that you have to show your income to get SNAP or like Meals on Wheels till you're 65. I'm worried about churn, people going in and out of Medicare eligibility, on and off of insurance coverage, especially for immigrants. I'm worried about reduced provider participation in Medicare and Medicare Advantage. We're seeing a lot of doctors and health systems say, I don't want to do this anymore, especially as they begin doing more prior authorization in traditional Medicare. Providers are really pushing back on that. As I said, I'm really worried about reduced staffing in nursing homes and opportunities for even more neglect and harm. I'm worried about the expensive coverage for people who are pre-Medicare through ACA. And I'm also kind of worried about Social Security Administration, and they've been closing offices, and a lot of people are no longer working there. So those are just a few things that I'm keeping my eye on as a gerontologist, and these changes go into effect. So that is it for my presentation. I hope I didn't talk too fast, and I hope I didn't lose a lot of you with that information dump.